Welcome everybody. It's great that everybody who wanted to put their name down, most of you arrived, which is fantastic. I know it's a Friday and I'm sure you've all got things that you're going to go ahead with after this. So I'm mindful of the whole day. My name's Tania and I'm one of the GPs in Tower Hamlets. First of all, a really big thank you for committing to coming. This is a little bit different in terms of how we're talking about cancer as a long-term condition, but also how we're trying to integrate lots of different people who work in different settings. What we've tried to break you up a little bit in terms of where you're all from, just to mix it up and have some really good conversations about integration later. We have got a timetable here. We're aiming to finish at 4:30. We can squeeze that a little bit if people need to. We'll just sense how you guys are doing. There's 3 group working sessions in the day, and there's 2 more sort of slide-based presentations from me, Zareen, and Becky. What's really, really important for us is that we try and evaluate this. You guys are the second cohort who've come to this training. And I know that normally you get evaluation forms right at the end and some people have already left, but please, please, please help us, because we've changed today based on the evaluation from the last group in May, and we've got another group in July. So we really do value what you think. A plug for that. And I suppose it's just, people say I'm the fluffy GP in the room. GPs are always getting called fluffy. Today's quite an emotive subject, and it might be more emotional for some. Some people in this room may have cancer or have had cancer. Some people have got a loved one that they may be supporting currently, and it's just a sort of rain checking on how you're feeling. The reason we've got facilitators in each table is if you're struggling for some reason or you want time out, just give us a signal or go, because it does raise quite a bit when we talk about some of the real cases that we've brought today. It's really useful to hear what you hope to gain out of the day. One of the things is that this isn't a communication skills course, just to put it out there, and I hope you all know that. This is about cancer as a long-term condition, and it will touch on a variety of times of need, including palliative care and end of life, but it's not a specific palliative care course, and it's definitely not communication skills, but it is about having conversations. And it's not just the conversations that you all have with your patients or your clients, it's about the conversations that we have with one another as well. So hopefully when you got the original email, you'd have seen what we really were about today is thinking about how do we identify a patient with cancer's unmet needs, no matter where they are on their journey, but also how do we support them and how do we integrate one another's work worlds to support that patient a bit better. So there are going to be aspects of pretty much everything you've brought forward in the afternoon, but it isn't just about the conversation you have directly with one individual person. So we hope that you're going to have an improved understanding of the impact of cancer and its treatment on that person's life, including the long-term consequences of the treatment. And I'll explain that in a minute and how they might change. We also want to make sure you have an improved understanding of how to enable access to more holistic joined-up care for people. We have got some resources at the end and some signposting, but it's absolutely impossible to signpost everybody in this room to every single place in Tower Hamlets. But we have pulled together a host of some as a starter for 10, but there are a few of many, but we can talk a little bit about that. And the third thing is actually, we want everybody to sort of build in confidence in your own personal ability, no matter what you're doing, to have a positive impact on a person's quality of life, enabling them to meet their own goals that they've identified. This is about how we walk out of here at the end of the day, maybe changing the way we might talk or what we might do to identify someone's unmet need, and then what we might be able to do to meet it in a better way together. Does that make sense, hopefully? Integration, you'll hear that word quite a few times, and we've got the third part, which is a little bit about integrated working as teams, which is really a big deal, seeing as we're all from different areas, and probably safe to say we're not the most integrated of a collective. Nowhere else in the NHS is, but that's about today. So part 1 is a little about cancer as a long-term condition. Part 2 is about how we support people's needs, and we've got some case-based real people, thanks to the Macmillan Social Prescribing Group and to the MLAT program. We've pulled together real people with real needs for us to think about as groups as to how we might support them. And the last thing is a little bit of an exercise, and part 3 is thinking about, so we're going to work better, right, the minute we walk out of this room. What can we all individually maybe do differently to be more integrated? So I'm going to fly through some of this. A few people talked about palliative and end of life. The reality is, and I think you mentioned it, is actually there is a massive changing story about cancer. Okay, so thankfully we are getting better at identifying people earlier, and they are living with cancer longer. Okay, so actually if you go fast forward to 2040, we're going to go from about 1.2 million people living with a cancer diagnosis to 5.3 million. So that means people who've had a diagnosis, and it could be a day later, or it might be 2 years later, or 5 years later. I've got a patient at the moment, I had a patient, unfortunately she passed away, but she was living with breast cancer, with metastatic breast cancer for 7 years. Okay, so she wasn't cured, she wasn't end of life or last days of life, but she was living with an awful lot of problems from that, and she met an awful lot of us in those 7 years. So I just wanted to let you know that we are going to be dealing with more people who've had cancer or who have cancer. And what does that mean to us in Tower Hamlets? I'm assuming you're all Tower Hamlets, roughly, to work. So how many residents in Tower Hamlet at the moment have a diagnosis of cancer ever? All right, so it's yesterday or a few years ago, 4,300 people in our borough at the moment have a diagnosis of cancer at some point. We know that every year in this area we get 600 to 650 new people with cancer. We know that the people who die is around 300 who go into last days of life annually. We know it's the biggest killer in our borough of premature death, so age under 75. And we also know that actually that this is shifting. People are getting younger with their initial diagnosis. The most common is definitely breast, followed by lung. We've got colorectal and then prostate. Every area in North East London has slightly different variability depending on ethnic background as well. So for instance, Hackney and Newham have much higher Afro-Caribbean population. They've got a much higher prevalence of prostate cancer than we do in Tower Hamlets. We know from local data that all those patients, surprise, surprise, don't just have cancer. They've got another long-term condition. So maybe in your role as an OT, Julie, you might have seen somebody who maybe had a stroke and you're doing some work with them, but they also had a history of cancer. So it's not just about cancer, it's about the person and how the cancer fits into that. We know that out of all the comorbidities, the predominant one is a lot of people have hypertension, but quite a few have all these other diseases. The reason that's important is in our last course we had practice nurses, and actually the practice nurses are seeing a lot of our chronic diseases, and a lot of those patients have also got a history of cancer. We divide it up into 3 groups. We divide it into group 1, which is people who live more than 10 years, group 2, which is similar to a long-term condition, and group 3, where the majority is very, very short-term. So for instance, pancreatic cancer we know has incredibly poor outcomes. Okay, and often actually they get diagnosed through A&E and don't often survive very long at all. Similar liver cancer. Whereas we know if you catch prostate cancer very, very early, people can live for a long time. And in fact, some people, the prostate cancer is not the thing that causes their end of life. Okay, and then we've got ones in the middle depending on stage. So uterus, or ovary, some of the kidney. So it depends a little bit on the stage of the cancer and the type. This just gives you an idea again of this is a big cohort of people. We're going to have a lot of cancer people, okay? But the problem we've got is if you've had a diagnosis of cancer, even if you've had a cure, you've had a lot of treatments, living doesn't mean living very well with it, okay? And this is the thing we need to start getting our heads around a little bit. So one of my patients, in fact the one who died, said, yes, I'm alive, but it's not that great, to be honest. But everyone keeps thinking I should be really pleased that I'm here. But actually, it's not brilliant. X, Y, and Z things are happening to me because of all the stuff, but I'm still here and I don't know how to really get over this to the health professionals because they just keep saying, well, isn't it great you're still here? I'm like, well, I'm not living that great actually. See, there are lots of slides like this and we're going to make sure we circulate the slide deck. But we know that actually quite a lot of people face fairly poor help. There's a huge amount of people with a massive emotional support need, and these are people who actually are 5+ years after their diagnosis. It's not the people that just had the diagnosis last week. We also know that a lot of the people, so 20% of people, have an unmet need. Something's going on that no one's identified. This is another slide just to give you an idea, but we're talking about a lot of people with, these are post-diagnosis, post-treatment, many years later, ongoing extreme fatigue that stops them working, stops them doing the things they want to do. We've got people with severe pain. Pain is often the one that if I said to anybody cancer, most people say pain or weight loss. But actually this is chronic pain. A lot of people with urinary problems, okay, incontinence. And actually again, something that they don't normally volunteer. The prostate cohort of men who've had radiotherapy often have quite significant urinary problems, incontinence, sexual difficulties that they don't feel very able to talk about. So as a group, with any of these patients, how are we flushing out some of these needs and what are we doing about them? And similarly, there's a lot of people who have quite a lot of gastrointestinal problems. I'm talking long term, years later, okay? So this is just for your records when you get back. So cancer, in terms of the consequences, and often the consequences is something we have done to them, okay? Nicest possible way. We've given them radiotherapy or chemotherapy, often surgery, and we've given them a consequence from that. And they stick around, guys, okay? So we've talked about not everyone living well. These are just a little bit more of an idea of more the psychosocial aspects. And I know when I do a lot of education with GPs, we like physical symptoms, okay? We talk about pain and fatigue and breathlessness, and it's all very comfortable and we know what we're talking about. But actually, the reality is there's an awful lot of people who've got significant psychosocial impact. So financial, housing, psychological, and if we don't start asking about it, patients, clients, people we meet in our circles, be they the carer who happen to have a history of cancer or the patient or the client, they don't tell you, okay? They're not quite sure if you're the right person to talk to or you'll be able to do anything about it. The problem is no one's asking. And a lot of these patients have touch points in this room. They might see me, I might send them at some point to BAVS, they might then meet an adult social care worker in the hospital, then they need an OT, they might then see someone for mental health. And actually, not a lot of us are picking up on what their needs might be. I really like this one because this reminds me to be non-medical. Okay, this reminds me to think about, are they mobile? Are they okay with just general function? Personal care and emotional care needs. So what's another thing that's come up quite interesting is work. So as GPs, I know for a fact, the last thing on my list of things to do in a 10-minute consultation is ask someone who's a survivor of cancer whether they've got any work issues. I do it really badly. So this is a little bit about saying actually there are significant, Macmillan have demonstrated significant issues with late consequences for people who've got cancer or who had cancer that impact on their ability to work and more importantly to earn the money they need to live the life that they want. This is another one just to demonstrate, you'll get bored of these little pictures, but you're going to have them all. To be honest, a lot of you in social care may be far more well versed with some of the impacts of work on cancer. Just a quick show of hands, has anybody met a client or a person who's had a history of cancer who you're specifically supporting around work or benefits related to their cancer? Do you think?
I do work or benefits, but these are people at the end of life.
Yeah, so sort of different. But I'm wondering, of all the people that said no, is it because they don't or because you haven't checked? I hope you're getting it, starting to sink in, is how do we identify these needs? Okay? I break them down roughly in my head to sort of emotional and psychological needs about that cancer, that diagnosis, the treatment consequences, the physical, the more personal, I think financial work and education. So some of the younger, the lady who was working with teenagers in terms of the impact of cancer on our younger population and what happens to their education or their degrees if they're doing that. And also what does their need around the information? What do they want? How do they want the information given to them? Does that make sense? We're going to go into a little bit more details with the cases. This is quite an important slide, okay? And this I quite like it. Sorry, it's a bit blurry, but it's about the fact that there are different needs across different parts of that patient or client's pathway, and they vary. Patients can go backwards and forwards and up and down here. All right? Now, some patients will go through this and live well after cancer and then unfortunately get a second cancer because of the treatment we gave them for the first cancer. And they start all over again. Or you might have someone who actually is living quite well and then unfortunately they have a recurrence and then they become end of life. This sort of demonstrates when are there times of need for that patient. So quite a lot of people I see, I probably see we do quite a lot of end-of-life care, but our numbers are not big. We're 13,000 patients and we get about 30 new cancers a year. At the moment, I probably have 2 people on my list who are end of life from cancer. The vast majority I see, I think, are the ones who've had cancer, who are back to living, but not living very well. And they're the ones that we're quite keen on understanding. Right. This is thanks to BAVS's program, this is social prescribing. So tell Hamlets, right, what's the problem? So these are patients who've come into the program of social prescribing and we've kind of get a sense check. The national data shows us all these unmet needs, what's going on in Tower Hamlets, and it pretty much mirrors it. Emotional well-being, finance, and physical activity. So people don't know if they've had cancer and they've put on some weight. They don't know whether it's safe to exercise, not safe, should they lose weight? Are we doing a good job so far? I don't think so, sorry. The National Cancer Patient Experience Survey is banded everywhere in every meeting about cancer. What do people say? What do patients say? The numbers are not big, guys. They're under 100 that are canvassed, and no one can tell me whether or not those 100 represent Tower Hamlets. How many of them are non-English speaking? You know, what ethnic background have we got to those people experiencing it? But there is a theme across the nation and in Tower Hamlets that actually half of them said that they thought their GP practice did everything they could support them, which we're working on in general practice at the moment. We're doing a piece of work around that. Again, about half said they got some information about financial support. Again, half said they were told about the side effects that are going to affect them. Again, half said that they're not sure if the person next to them, their carer, was given what they need. And about 40% said they weren't given enough support from social care services during treatment.